Sandy gave me was a fairly broad one, and I'm going to move around a little bit because many of the things in this talk will be covered in further depth by some of the other speakers. But I want to give us all sort of a framework for understanding some of the principles that go into when you select various kinds of equipment, what you should be looking for. And so I subtitled the talk, The Right Stuff. I think after the diagnosis of transverse myelitis and after all the dust settles in terms of the medical issues, I would imagine that you find yourself on unfamiliar territory. This is a brand new landscape. There's a lot of uncertainty involved with what choices to make, who do I go to, and it's pretty rough terrain to navigate. You're quickly put into this situation where you have to make choices. How do I choose the right stuff? So I chose this picture of a Cheyenne medicine man, and that's the stuff he chose. He chose spear and a wolf skin and a shield. They were all designed for certain purposes, and they all had reasons for why they were chosen. And I think when you go through, your selection process, one issue that comes up pretty quickly is mobility. What are the things that I'm going to need to use to help my child move around? What are the purposes of these devices that I'm looking for? And what's the best design for different items that do the same thing, have the same purpose, but maybe one company or one manufacturer has come up with a more useful design. And these are all things to think about. There are websites out there. Some of them are in your handout. Design, people who go to design school specialize in designing environments and wheelchair devices, adaptive equipment specifically for the purpose of enhancing function. And just as an aside, I contacted one of these designers. Her name is Cynthia Laybrock, and I'm going to be referring to some of her work later on. She was kind enough to send me 2 books that she's written, and they're outside on a table for you to take a look at. They go over designing your house or designing your surroundings in terms of optimizing access. Another topic Sandy asked me to talk about today were some of the orthopedic issues that come up when a child or an individual has transverse myelitis. So at the end of the talk, I am going to talk a little bit about orthopedic issues. This is sort of the sequence of factors that might go into why children with transverse myelitis have orthopedic problems. It all starts with a loss of passive joint mobility, which over time can lead to fixed contractures, and we'll define contractures later on. When you can't move your joints through the full range of motion, oftentimes the end result functionally is a loss of stability. And if there's weakness in the trunk, as we just heard earlier, scoliosis is sometimes an outcome that you see. I just mentioned this as well. One thing that goes along with choosing the right stuff, the right equipment, is optimizing the environment that you will be using that equipment in. These are 4 environments to consider. How you set up your house and some of the things you can do to adapt your house to make it more accessible. The school, we heard in quite a bit of detail yesterday about the responsibilities, the obligations of the school system to design that environment. Recreation, we've also heard from our recreational group about the opportunities, the different things that people can use for optimizing their recreational environment. And the car, transportation, car, van, is a 4th environment to consider and to think about before you make a purchase as to this van or that car. Make the purchase carefully, and again, the internet, as I'm sure everyone in this room knows, is an amazing resource. When I went in there to look up sites for wheelchair accessible transportation, I quickly got lost in all the different sites that were available. This diagram is one way to conceptualize the different kinds of environments that we're dealing with. There's the immediate environment that affects the individual, which is basically defined as anything that comes in contact with that person. So a wheelchair is pretty much a very key part of the immediate environment. You can see it, things such as reachers or aids to dressing or undressing would be also part of the immediate environment. Surrounding the immediate environment is the intermediate environment, which you could define as the personal living space of the person with the disability. And that intermediate environment is in the circle of the community, and the community has also been adapted and changed to become more accessible for someone with a disability. Now, outside of the circle is what is termed the natural environment, and that's the challenge. That's the space that has not been adapted for people with special needs. And that's, again, one of our challenges is to make the natural environment as accessible as possible. Now, this didn't come out very well in your handouts because of the size of the print, but I also put it in the handout several pages of information, of very practical tips and hints as to how to change your intermediate environment, the personal living space, to adapt it to someone with mobility deficits. And as I read through the list, getting ready for this talk, I was amazed by all the things that were on it, all the little things that you might not think of the first time around. But I'd like to just go through this list here, because these are some of the standard recommendations, and then you could also refer to your books for some more detailed information. Doorway width, that's an issue. You have to make sure that the doors are wide enough. And they usually require a straight shot so that the wheelchair can go straight through without turning. Standard recommendations are 32 inches for a manual wheelchair, 34 inches for a power wheelchair. Again, my guess is that with the wheelchairs that are currently in use, you should probably make them slightly wider than that to accommodate things that are hanging off on the side. When a turn is required to get in the house, the doorway width should be at least 36 inches. A minimum turning space when you're planning for a 360-degree turn is felt to be about 5 by 5 feet, or about 6 by 6 feet for a power wheelchair. And the maximal threshold height that permits a wheelchair to cross with the minimal jarring is about 1 inch, so about 1 inch in terms of your door setting. Light switch and push plate heights, about 36 inches. And I think I was going to say 1 inch keeps coming up in terms of remembering how to build some of these ramps and accommodations. We'll talk about it in just a second. The rest of this table goes into physical conditions that are recommended about the home. The area for a person with a spinal cord injury should be well insulated, have stringent temperature control. That doesn't tend to be too much of an issue with TM, I don't think. How many of your children have problems with temperature regulation? Okay, so it is a bigger issue. So make sure that you have environmental controls that keep the temperature at a fairly constant level. Eliminate throw rugs. They are difficult for people in wheelchairs to roll over. remove or rearrange furniture that will impede wheelchair access, and so on. So these are all some of the things that you can think about when designing the intermediate environment for someone with disabilities. This is a picture of an adaptation in a trailer. These ramps, can be attached to any kind of house in any kind of environment. You sometimes have to use your ingenuity and get someone who can figure out whether we're going to need a ramp or a wheelchair lift to get in the house. The general recommendation is that the length of the ramp should rise no more than 12 inches for every inch of height. So the ratio is 1 inch of height to 12 inches of length. And if you had a walkway that went around your house, the general recommendation there is a 20-inch rise for a 20-inch length. For a 1-inch rise. Another practical suggestion would be, oftentimes if there is a storm door on the door, it's easier if the door swings in rather than swings out. So you might want to change that orientation. In the area of recreation, I know we talked about recreation earlier, but we're seeing more and more of these kinds of swings in public places. And the advantage is that the child can use their arms to propel themselves in the swings and get a sense of freedom and motion with them. There are all kinds of wheelchair sports, as I'm sure many of you know about, and they go from the fairly benign type of sports such as sailing or cycling to the more aggressive and competitive. Well, I guess sailing is also competitive. I really shouldn't use that term, but the more aggressive sports such as wheelchair rugby, basketball, downhill skiing, and you've probably seen pictures of kids in wheelchairs in these adaptive skiers, and they go right down the slopes. It's pretty amazing. The caution that I have about this subject is that there is a rising prevalence of injury of individuals who participate in a lot of these sports. Just as there's an increased prevalence among all athletes. But it is something to think about, and it's something to train for, and to use the same kind of precautions that you would use in individuals who don't participate in wheelchair sports. These statistics are pretty broad. About 26% to 97% of people who are involved in wheelchair-related sports suffer some kind of injury. Surprisingly, only about 16% is trauma from the sport, and most of the injuries, over half, are from overuse syndrome, muscle strains or sprains. The upper limbs tend to be more involved than the lower limbs, but you do get back injuries and you get leg injuries as well. A joint that's specifically vulnerable for individuals who are involved with wheelchair sports are the shoulders, because the shoulders really weren't designed to take as much force as is required for many of these activities usually. So these shoulders are very vulnerable, and you have to pay attention to joint mechanics and make sure that an adequate range of motion and stretch occurs before and after the activity. This is an area where people with paraplegia, such individuals with transverse myelitis, spinal cord injury, continue to push the limits. There are rock climbers with paraplegia. In 1989, Mark Wellman scaled El Capitan in one issue that comes up a lot is mobility. The question is, will I walk? How much will I walk? What's the what's the cost going to be in terms of energy and fatigue with walking? It's the most commonly posed question that we get. There are some guidelines as to making a guess about what the ambulation potential of an individual person is going to be. But let me say at the beginning that individuals with spinal cord injury, transverse myelitis, you really can't tell them what they can do. A lot of times you might look at the neurological examination and say, well, the statistics show this or show that, and then they come back and they surprise you. So I think it's important to think about what these guidelines are, but I think for every individual person, it's a combination of factors. Some of these determinations of ambulation potential are energy expenditure, how much energy it takes to move, spasticity, how bad the spasticity is and how well under control it is, whether joint contractures have occurred in the face of this spasticity, and whether there's the presence of pain, which may also be another factor that would limit ambulation potential. We tend to talk about 4 categories of ambulation: community ambulation, household ambulation, ambulation for exercise, and the non-ambulatory individual. And the definitions, I apologize for the fuzziness of this slide, but pretty much this is what they're defined as a community ambulator uses ambulation as the primary mode of mobility. Household ambulator walks within the home with relative independence, uses a wheelchair as primary mobility in the community. Exercise requires considerable assistance or energy expenditure too great for ambulation to be functional. And then finally, there's the non-ambulatory person who uses the wheelchair entirely. It's pretty much felt that in order to be a community ambulator, some degree of pelvic control with at least fair strength in the hip flexors on both sides, and at least one knee extensor muscle, such as the quadriceps muscle, is needed. That roughly translates into the spinal nerves at the lumbar 2 and lumbar 3 level need to be intact and functional for the hip flexors, and for the knee extensors, it's generally felt to be lumbar nerves 3 and 4. So you'll hear people talk about spinal cord levels or levels of involvement. And generally it's felt that you need these muscles working or these nerves working. But after saying that, I think a lot of individuals with higher levels of involvement, let's say low thoracic levels like a thoracic 10 to thoracic 12 level, are community ambulators or have good days when they have a lot of energy and they don't need wheelchairs. They use their small strand crutches or they use some other type of crutches to walk. So there is some individual variation as far as this goes. Now, here's another table that is from the American Academy of Physical Medicine and Rehabilitation. It's a table that was related to individuals with traumatic spinal cord injuries, and it's basically an attempt to look at what the percentage of people that ambulate after 1 year of a traumatic injury are based on their neurological examination. And LEMS stands for lower extremity muscle score. It's just a way of adding up the muscle strength in a number of key muscles, and you get a score when you finish adding up those numbers. If a person has an incomplete tetraplegia all four limbs involved, sorry, and the lower extremity muscle score at 1 month is 0, their potential for ambulation was not applicable. Those individuals will definitely be wheelchair ambulators. Non-ambulators. However, as you go down the list, you'll notice that's the only non-applicable category on the table. Individuals with complete paraplegia, that means the legs don't work, with a lower extremity muscle score, which is pretty low, which means that most of those muscles are really weak. 45% were ambulation at 1 year, which is pretty good, quite a feat. The incomplete, now the difference between complete and incomplete, that's the way we evaluate individuals with traumatic injury as to whether someone's a complete spinal cord injury by definition if they have no sensation in the rectum. If there's no rectal sensation or there's no reflex contraction of the rectal muscle, we define those as complete spinal cord injury patients. Incomplete is if they have some sensation in that area. And for those individuals which are incomplete, you can see that there is a pretty good prognosis for ambulation at 1 year after the injury. The potential benefits of ambulation, these are three. The ability to overcome functional barriers, increase self-esteem, and cardiopulmonary exercise. And I think all three of those are valid and important benefits and are reasons for us to pursue optimizing an individual person's ambulation potential. And then just to kind of summarize, the level of neurological predictors for ambulation, a level of injury below thoracic level 11 is associated with an increased potential for ambulation, but it doesn't rule out ambulation if the level is higher than that. Complete tetraplegia do not become community ambulators. And I think it's important to realize that chronologic age by itself is not a prognostic factor. The more important prognostic factor is cardiopulmonary status. It's been estimated that because of energy demands, you burn up 3 to 9 times the number of calories depending on how much neurologic injury you will have when you ambulate. So it's a very energy intensive activity, and that oftentimes is more a significant prognostic factor than age or even level of injury. This is a slide that I got off the internet, and basically it gives you sort of a rough idea of, depending on what level of neurologic involvement an individual with spinal cord injury or transverse myelitis has, what kind of mobility device is most likely to be used. So someone with a cervical level lesion can get around with a powered wheelchair down to between cervical 6 and 7 levels down to lumbar 2. Oftentimes, various kinds of manual wheelchairs are used partially or most of the time. Once you get below the lumbar 2 level and you're using your hip flexors and your knee extensor muscles, it's when we start talking about the different kinds of walking aids, such as ball strap crutches, different kinds of braces or orthotic devices, such as AFOs or KAFOs. And Mary Jo is going to be speaking about those devices in more detail when she gives her talk. Orthotic devices are basically braces that give support for standing or for walking. They come in various sizes and shapes, and again, most of you, I would say probably all of you, have seen these devices in various shapes and sizes and types. three types of devices that we might be recommending for children with transverse myelitis include a hip, knee, ankle, foot orthotic device. One example of that is called an RGO, or a reciprocating gait orthotic. Another kind is a knee, ankle, foot orthotic, also known as a Scott-Craig brace. And then this is a picture of a molded ankle, foot orthotic device, which would be used for children with pretty good knee and hip control, but ankle instability. When we talk about rehabilitation for ambulation training, these are three of the components that the therapist will be working on: strengthening of the lower and upper extremities. Both are needed for effective mobility. Trunk control and pelvis control are going to be real important in terms of balance and weight shifting, and being able to stabilize your joints, at least momentarily, so that you can take another step, because to move forward, you're going to have to shift your weight back and forth, stabilize on one leg as you move the other leg forward. Just a quick word about therapy, and maybe Mary Jo will emphasize this as well. One of the issues with therapy is that it tends to be a very boring and labor-intensive intervention. You don't, day to day, you don't tend to see a lot of change. But the problem is, if you don't keep up with the therapy, and I know it's really hard to do, over time you might see some of these secondary orthopedic problems creep in, the muscle contractures, the skeletal deformities. So one thing that I tell patients is I encourage them to think of it like they're brushing their teeth. You know, we brush our teeth every day. It's just one of these habits that we get into. If we don't brush our teeth for a week, we might have some bad breath, but you're not going to see your teeth fall out. Your gums aren't going to start to bleed. But if you don't brush your teeth for 6 months or 12 months, that's when you start to see the problems. So from day to day, you're not going to see a whole lot of change. You might say, well, this isn't any good. I'm not making any headway here. But I would encourage you to keep at it. Now, the problem, of course, is time, the schedule. How much time does it take for therapy? Unfortunately, there's not a whole lot of great research out there that's really looked at this. And part of the problem is it's hard to set up a research study in a controlled scientific method way where you can say, okay, I'm sure that this group got X amount of therapy and this group didn't, and to do it in a consistent fashion for a large enough group. Some of those studies are just starting to come out in the scientific literature. There was a study from Canada in developmental medicine and child neurology about 5 months ago. It basically, and this again was not transverse myelitis, a group of kids with cerebral palsy. Basically what the study showed was intensive short-term therapy consisting of I think it was it was 2 or 3 sessions per day for 3 days per week for 4 weeks. Showed a better outcome on the short term than quote unquote standard therapy, which was therapist-directed therapy once a week for 20 minutes. Studies like that are very hard to find and very rare. And it's a pretty controversial subject in terms of what's the dose of therapy that's needed to get the outcome that you want. I would encourage you to try to find a happy medium. I think there's certainly the danger of overdoing the therapy, and what you end up with are some of these overuse musculoskeletal problems that you see with the wheelchair athletes who get out there and they're out there practicing every day and they blow out their shoulders or they tear a muscle. But on the other hand, just giving sort of a passing, whiff of therapy every now and then isn't going to work either. So you have to find out, with your therapist help, exactly what's going to work for your child in your situation. And try to, find the right balance. I'd like to spend some time talking a little bit about wheelchairs. I think that's a subject that hasn't been covered so far. And what I'd like to do is go into some details about how we select different kinds of wheelchairs, some of the questions you might want to ask your wheelchair vendors, some of the issues that are involved with finding the appropriate seating pattern for someone who's in a wheelchair. This slide basically shows you 4 different kinds of wheelchairs, and none of them really look like the wheelchair that your child's in, probably. The goals of having a wheelchair are to prevent or accommodate orthopedic deformities, to prevent skin breakdown from pressure, to provide trunk stability, to enhance arm function. These are all things that wheelchairs can provide. To promote independent mobility and to facilitate independence in activities of daily living. Wheelchairs, there's lots of choices when you select a wheelchair. And those choices can range from the type of tires, type of rims, types of lap trays, with a full lap board, half lap board. Some individuals need a forearm trough, different sidebars. So there's many different things to go through and to think about as you work with your vendors or your therapists in picking the right wheelchair. Cushions become a big issue. The technology of cushions keeps changing. There's different kinds of gels, different kinds of foams. Finding the right one for your child will be an important aspect of wheelchair selection and putting together wheelchairs. So let's start with planning a seating system. One of the things that I do when I see someone for a wheelchair evaluation is I always start with the pelvis and start with the seat, and then go out from there in terms of the back of the chair and the kind of footrest, those things. There's 3 things to think about when planning a seating system. One is the angle between the seat and the back surfaces. Second is the question about, do you want a tilted space wheelchair? And the third aspect of planning a seating system is the type of seating surface to select. The angle of the wheelchair, by that we mean the angle between the seat and the back of the chair, should be whatever is needed to maintain the pelvis in a neutral or slightly anterior pelvic tilt. What that means is you want the pelvis of the child as they sit in the chair to be rocked slightly forward, or in what we call a neutral position. You don't want it to go backwards, causing the child to slump in the chair. And the angle should also be optimized to provide the proper lumbar curve to the back, so you maintain the alignment of the back in as stable a position as possible. Some children, some individuals will need the angle of the chair to be open. So you might hear people talk about opening up the angle. What they mean is opening into more than 90 degrees. And that's going to be needed if your child doesn't have a 90 degrees of flexion at the hips, because of joint contractures or soft tissue contractures that cause the hips to extend. However, you have to be a little careful with that, because if the angle is over 90 degrees, there is a possibility that you can trigger spasticity in some of the back muscles, and cause these extensor muscles to fire, which would increase the lumbar curve. So it's a matter of trying to find the optimal angle of the back. Along with the angle of the back, there's the tilt of the back and the seated space. Now, if someone's in an upright position, that's like this picture shows, and they've got poor trunk control, sometimes, and a low tone trunk, sometimes to compensate, extensor muscles come into play, and the child feeling that they're falling forward compensates by extending their shoulders and extending their back muscles, putting them in a position that's not very functional because their hands are back here. So one of the things that has to be thought about is what are our upright support options in a situation like this. And there's three options that we could talk about. One option would be to use a variety of anterior harnesses or chest straps. Another option would be have something for the child to lean on to give them support, like a tray. But probably tilting is the place to start with. Sometimes a slight tilt may be enough to sit in a more upright position against gravity. So slight tilt the seat back a little bit may help maintain that position without having to go to some of those other things. So it's important to talk about, does the wheelchair that you have a tilted base, which can provide the adjustment. Now, another key reason for a tilted space is pressure relief, especially under the ischial bones which you sit on, and the tilting is required to do that pretty frequently during the day. And I'm sure you've been told about the importance of doing that to avoid skin breakdown and other problems. The next aspect of the seating system is the kind of seat, the type of surface that you're going to be sitting on. And basically you can think about this as coming in three types. There's the planar, the contoured, and the custom molded kind of seat. The planar types of surfaces are nothing more than flat surfaces that the individual sits on. And these kind of systems are really for someone who's got pretty good movement, pretty good ability to readjust their weight when they're in the chair, and pretty good control of posture with minimal assistance or upright sitting. The things that you have to worry about with any of these seating systems are pressure on the bony prominences, which would be the ischium, which is at the bottom, the sacrum, and then the upper thoracic regions of the spine. And those are good areas to check on a routine basis for pressure or for redness that's not going away when the position is shifted. That might be an early clue as to possible skin breakdown in those areas. The standard kind, the contoured kind of systems can often be broken down into several kinds. This would be an example of a simple contoured system, and this is essentially made of foam that will be reshaped in response to body weight and to body warmth, and it kind of takes on the contour of the person who's sitting on the foam. And this works well if there's not a lot of extensor tone or shifting when you're sitting on the seat. Sometimes additional support might be needed to hold the person in place. So you can add blocks to the sitting surface to provide sideways or lateral supports as well as supports in the front and the back. And these would be more aggressive seating options. Here's an example of a high-density foam shape that can be placed under a more flexible foam to create this kind of a customized molded cushion. So depending on your child's needs, they may need just a simple planar surface with no cushion, going up to a more customized high-density foam contoured cushion. Some of the questions that you might ask is, does the seat provide enough support for my child? Is the seat the proper depth? And that depth needs to be changed, of course, as your child grows. And does the seat provide enough pressure relief? So these are all important questions to think about as you look at your child's seat.
How often should you evaluate this?
I would say once a year or sooner if you need to. If the child goes through if they're complaining, oftentimes parents will come and they'll say, you know, he's grown a lot and he just doesn't fit in the wheelchair. So I think you'll know just by looking at how they're fitting and also how their skin looks. I'd like to talk a little bit about the pelvis and the lower extremities with respect to the wheelchair. As I mentioned before, we build out from the pelvis when we design a wheelchair for an individual. The space needs to be stable and symmetric and supported. And we talked a little bit about asymmetric positions. So a firm sitting surface provides a good base of support from which a child can access the environment without feeling like they're tilted over and one arm is going one way and one arm is going the other way. So firm sitting surface provides a good base of support. Another thing to look at is the back surface, and questions that you might ask there is, does the back surface provide enough support? Again, is the seat a proper depth for the back, and is the back port high enough? One thing that's often built into some of these wheelchairs is a good lumbar support, which may help maintain good alignment in terms of how the spine is. And again, this is an important feature when you tend to have thoracic involvement with decreased innervation to the paraspinal muscles and a tendency towards scoliosis. So it's important to pay attention to how the pelvis sits in the wheelchair seat, and that there's not an asymmetric a bend to one side or the other that might start to predispose that spine to curve one way or the other. Here's an example. If the seat is too deep, then this will cause the pelvis to tilt backward, causing the that should be back to round, not pelvis to round. So the seat on the left-hand side is too long for the length of that child's leg, upper leg, and so he's forced to sit sort of scooted out from the back of the chair, and that causes that lumbar curvature. By making the seat shorter, they can sit straighter at more of a right angle at the pelvis. Question about, is the back support high enough? So if a child or an adult has fair trunk control, the back of the wheelchair should rise to about the middle of the shoulder blade. However, if it's a child with poor trunk control, the back should go higher to the top of the shoulders. And if there's increased extensor tone where they tend to arch in the wheelchair, again, the back should rise to the top of the shoulder. This is not a seat belt. We like to call it a pelvic strap. The reason that we shouldn't think of these as a seat belt is because we tend to put seat belts a little bit higher over the waist, not across the pelvis. And what you really need that strap to do is to pull the pelvis back into the juncture of where the seat and the back come together. A belt across the waist will encourage this posterior pelvic tilt, which I've been talking about as something that you want to avoid when placing someone in a wheelchair. One option which can be used, but I don't think would be used too often in kids with transverse myelitis, is a rigid bar which might be clamped into the seat of the chair. We tend to use this more for kids with cerebral palsy who have a lot of extensor muscle tone. But if there is a situation where the child kind of pops out of their wheelchair and you can't get that pelvis really snugly in the seat, a bar such as this one might be suggested. And then another way to try to make sure that the base of support is symmetric, that the pelvis is well controlled, is to build in hip guides to control the position of the pelvis in the seat. Another area would be knee supports. Sometimes a spacer may be needed to keep the legs in a neutral position. And if a spacer is needed, it should start at the front of the knee and move about a third of the way up the thigh. We we don't like to use these kind of pommels or spacers for people who have extensor thrusting or tone, because they tend to move forward and hit themselves against the pommel. So you got to be careful about that. You don't want to cause any trauma as a result of those supports. Trunk supports can also be built into a seating system. Where'd I go? To try to maintain the position of the spine to decrease the tendency towards scoliosis, or for leaning from one side to the other from muscle imbalance. So it's important to try to align the spine as much as possible using lateral trunk supports. And we oftentimes will recommend a 3-point control system, which is needed to maintain the position. So as you see here, you could build in supports in 3 places to try to push the spine straight, or keep it sort of in a straightly aligned position. Another issue that comes up is the proper position of the straps. It's very important. The strap should pass over the shoulders to a point slightly at or slightly below the shoulder line, and then the bottom should be securely tethered. I'm going to talk a little bit about straps. You want to avoid this kind of a strap, which is called a Y strap. These tend to bind against the side of the neck and put pressure over the neck blood vessels. Straps that tend to work well are H straps, but they should not be tethered to the lap belt. So on the left-hand side, you have an H strap that's tethered to the seat belt or the waist belt, and that's riding up over the stomach, and the H part is sort of catching the child underneath the neck. They should be securely tethered to a lap belt so that they don't ride up under the child's neck. There are other devices which are also used for weight-bearing activities and mobility exercises. I think Mary Jo is going to go into more detail about things such as standing frames and gait trainers. So I'm not going to touch upon those in any more detail. The last part of the talk is sort of a bonus. It's called orthopedic surgery, should we or shouldn't we? And I think this is a question that you may or may not need to face as your child develops. The decisions to treat an individual with a spinal cord injury is based on the degree of soft tissue contracture that has evolved in that individual. And that question is often based on whether the joint range of motion covers a functional range. So you could have a situation where there's a musculoskeletal contracture, but it hasn't progressed to the point where it's interfering with function. You may not want to do orthopedic surgery in that case. And there's got to be a belief, of course, that surgery will improve the natural history or what's coming down the road in the individual that receives the surgery. These are some pictures about various common contractures in the lower limbs that we tend to see and refer to orthopedic surgery to correct. The first picture doesn't show it very well, but it's related to tightness of the gastrocnemius or the calf muscles, and it causes the toes to point and turn inward, a condition known as equinovarus. Striatal toe, that is basically the extensor muscle to the big toe, gets tight and shortened, toe pops up, and that can be very difficult and painful in terms of wearing shoes. Stiff knee contractures, that's related to when the quadriceps muscles become tight and shortened and results in something called a stiff-kneed gait pattern. Flex knee contractures, that's oftentimes from tightened hamstring muscles. And that's why a lot of times we're always emphasizing stretch your hamstrings. And adducted thighs, that's often from the muscles on the inside of your legs being too tight, causing a scissoring type of pattern. But these are all types of muscle contractures that could be addressed through an orthopedic surgical approach. Just a few words about, well, what are contractures? Mobile tissues are usually separated usually separated by thin layers of loose aurelial connective tissue. I can hardly read that. Basically, when you look at joints, they're packed in this kind of pliable, slippery tissue that allows the joint to move back and forth. That's what we loosely term the soft tissue. There's also muscle contractures, too. The muscle also moves joint back and forth. If you immobilize a joint, either through casting or through an injury, this soft tissue becomes reorganized and basically becomes stiffer. It's not as pliable. And once the soft tissues are involved and that muscle becomes less pliable, less mobile, the muscle is physically limited to a certain range, and the muscle itself can also become shortened, and over time physically lose what we call sarcomeres, which are the little elements in the muscles that cause it to contract. So you can lose muscle length if that muscle isn't ranged or moved through a full functional range of motion. So one of the goals of therapy, and one of the reasons for why we do range of motion every day, is to prevent that series of events from happening. Despite our best efforts, oftentimes these contractions do occur, and we refer patients to orthopedics. And there's three major goals of orthopedic surgery. One is to remove or diminish the muscle imbalance that occurs around key joints that predisposes them to joint contractures, soft tissue contractures, subluxation, or dislocations. The major joint that we worry about is the hip joint as far as a dislocation. Preventing a bony deformity would be an example of that. And then correcting a bony deformity is something that we end up referring to orthopedics for when there, for example, is a problem with the foot, and the foot is now in a position that doesn't provide a good stable base. There are procedures that can be used, such as an arthrodesis, which is a fusion of the bones in the joint to reposition the foot in a more stable position. So you can think about three types of surgery when you talk about orthopedic surgery. There's muscle tendon surgery to restore the dynamic alignment, and this also improves the balance between the agonist and the antagonist muscles that were referred to in the previous lecture. And osteotomy is where they actually cut the bones, and it realigns the relationship between different bones, and it also is sometimes used to correct twisting deformities of the bones. And then an arthrodesis is where you actually fuse different bones together, so you have a very stable set of bones, but you lose motion in those bones. And where that's most commonly done is in the foot, and that's done to stabilize severely subluxed, which is bones that have slid out of position, or painful arthritic joints. These are just some examples of the musculotendinous procedures that can be done. You can lengthen the tendon, and these are just some names of some of the procedures that are commonly done. The first one is basically your heel cord lengthening procedure, and then the hip adductor tenotomy, you might hear that term. That's the operation that's used when someone is tightly scissored to actually cut the tendon to open up the legs to decrease the scissoring. Another procedure that orthopedic surgeons will use is called the lengthening of the musculotendinous junction, or the fascia. They'll just slit the tendon or the fascia which is the covering of the muscle, so that you can then, in the operating room, manually lengthen the muscle without actually having to cut through the tendon. And these are the different names for some of those procedures: the Strayer, the Vulpius, or the Baker lengthenings. I'm not quite sure what the details or the differences are between those three, but there are three different ways of doing that. I think that when you go to consider an orthopedic intervention, it's important to define what the functional problem is. Is it there's a joint contracture and the problem is loss of passive range of motion? And is that loss of passive range of motion, which means the motion that you can get when you stretch the muscle, is it from the muscle or the tendon unit, or is it from the ligament or joint capsule that surrounds the joint? And these are things that the orthopedic surgeon will be able to tell. Are they going to surgery because the gait's getting worse? And a situation where that comes up is with growth and with age. Child may be ambulating fine when they're 3 or 4 with the assist of AFOs or maybe crutches, and then they're 9 or 10 and they're taller. They may not be ambulating as well, and you have to decide, is that because of a change in their energy expenditure? Is it that much more difficult for them to move? Is it because of growth? Is it because of some neurologic problem? Because if there is some progressive neurological deterioration for whatever reason, we need to rule that out first before orthopedic surgery. Is the reason for surgery a joint instability or a twisting problem of certain bones, most commonly the tibia, the femur, and is the reason for the surgery to correct those problems? Or is the problem pain, and can orthopedic surgery help with pain? Where we run into that is regarding hips. Sometimes when you have a hip dislocation, that's painful, and the surgery is done to decrease the pain. Okay, thank you for your attention, and I'll be happy to answer any questions.
Before Dr. Pidcock takes your questions, I would like to acknowledge and thank you in front of these parents for taking on double duty to do the orthopedic part of this presentation. I don't know how I did this. There's one major pediatric orthopedic practice in Columbus at Children's Hospital. Instead of going through the 14 doctors in that practice, I went directly to the chair of the department. Somehow I alienated this person and left myself unable to get to the 14 or 15 or 16 other doctors in practice. And so I came to Dr. Pidcock and asked him to please pick this up, and I thought you did a great job with that. And I appreciate it.
Any questions?
Yeah, any questions? Yeah. Oh, yeah. Has she always had the arch, or is the arch getting? The arch is probably getting that way because there's weakness of the various muscles that control the foot. Usually those are fairly pliable, and if you have a well-fitting AFO, you can mold the AFO to account for the arch. Is it painful for her? Is it hard? Not yet. And yeah. I don't have any specific recommendations for that. Usually what we do is that we don't want to accommodate a deformity that we think we can make better. So you don't want to put someone in an AFO or a wrist split if we can get it straighter, or if we can get it flatter. But that being said, people do have high arches. They do run in families. There might be, yeah, but it's more than that. So I think you'd want to accommodate that part of the way, but probably not go to a flat AFO. So I'm taking the middle ground between the two people that you've gone to. I don't know, Barry, Joe, would you want to comment on that question about, or anybody?
A lot of it, when you look at feet, you look at the brace that they're in and try to make them as comfortable as you
think the rule of thumb is, pretty much comfort. And so if you get the AFOs that are flat, she's not going to wear them. That's not going to help. Yeah. 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 Okay.
I was just wondering about power assist wheelchairs. I remember last year, there's most incidents, I want to say, in the news. And I was wondering about pediatric one.
No, I've heard about the power assist wheelchairs, and they sound great. What they are wheelchairs that are kind of a hybrid between the manual and the powered chair. So you don't have to use as much energy to move them, but they do require some strength and some exercise. I've not seen them in the Baltimore area, so I'm wondering whether the company that makes them is having trouble getting them out, or they just haven't hit the East Coast. Oh, that's right. You're the one that gave the talk.
I could answer that now, or
Maybe you can answer during your talk. Okay, that's great.
A gentleman in my community who is an adult, he uses a wheelchair that actually puts him in a standing position.
Right.
And he really likes it. I mean, he became an EMTM as an adult and feels like being able to look people in the eye.
Right.
You know,
I've also
feels
seen
better
one of
about
those here.
himself. Pardon me?
I've also seen one of those here.
Have you? Okay, so I
It's
was.
standing.
for
Who's got that?
Especially like a teenager, I was thinking, if you're not growing, is that, something people should look at?
Yeah, well, we just visited, we just moved to Iowa, so we're trying to establish new medical care, and we visited the head of physical therapy at the University of Iowa. It's a Richard Shields, and he has huge grants from the National Institute of Health, and to bone density studies, because he says, for standing, you can explain it more, what he's doing. But if you qualify for his study, you can get one of those wheelchairs that go up and down. And the only reason Laura might in the fall with the newer study that he's going to do, but right now she won't because she can't benefit. She's the lower motor neuron damage, and they can't find very much nerve, and so she doesn't qualify for the EMS. But it has the EMS built in with the wheelchair, and you press the button and you go up and down. And he's saying that he believes that this up and down motion is more important for maintaining bone density than just standing up and walking around. He says it's just the up and down changes.
That should be very interesting research, because I think
Yes.
people have had different ideas about whether you do increase bone density with standing or not. So I think this is work that needs to be done.
Yeah, and
to
if
sh-
you qualify for his study, if your child needs electrical muscle stimulation, basically,
Yeah.
you go see him, you're in his study. It's funded by the National Institute of Health, and they will buy you the wheelchair to go up and, it's an $8,000 wheelchair from the
Oh.
Levo Corporation.
Okay.
Do you have to give back at the end, or you keep?
No, you keep. And, we're sitting here thinking, we're sitting here thinking, well, how can we get one?
What are the age ranges?
Anybody, I think he's doing
Any
anybody
age?
and everybody.
Every age.
Right, I have 23 volunteers here.
Yeah.
Well,
Yeah. It's
Yeah.
Richard Shields at the University of Iowa. It's, he's in the graduate department in physical therapy. He's the head of, the National Institute of Health. I read it on the internet, a couple months before we moved up there, and I said, when we move up there, we're going. We moved up there a month and a half ago. We met him about a week and a half ago, and he went ahead and did the bone density scan on Laura because, to see where she was. He didn't have a norm, at the
Mhm.
beginning, a year and a half ago when
Right.
this happened, but he could tell
Yeah.
us at least where she fell.
Right. Yeah.
He's gonna do another study starting in the fall on vibration,
Mhm.
standing with vibration. And the reason it's so big is because the astronauts and stuff not being able to, they
Right.
found that the muscle stem itself is not really help that
Sounds very,
Call us back in the
sounds very interesting.
Yeah.
Yeah, it's great.
All right, now we have a question?
Say that again, a spacer?
I didn't hear.
Okay, is the spacer,
I just saw the spacer, the picture of one here. That little.
is that the standing frame or the?
No, she walks, but she's starting to.
Keep her legs apart?
Yeah.
Yeah.
She's sitting at school or.
You kind of want to use the least restrictive bracing systems that your child needs. There are some kinds of braces which have a spacer mark in between them to promote walking without the legs getting tangled up. So it would depend on the kind of braces that she's currently using. Do you know the name of them or what kind of they are?
She was wearing ankles, but she's not wearing them anymore.
She's not wearing any.
After the surgery, no, she's not wearing any braces.
So the problem is that her legs tend to scissor while she's walking?
Yes.
And can she move them without scissoring, or do they get in the way? Does
She
walk
can,
along?
yes. She can, but it's starting to go that way now,
Yeah.
so.
Yeah, what we sometimes we'll use our other interventions to try to improve the walking pattern with the therapy. One example might be Botox. If she has tight adductor muscles, we'll treat the adductors with Botox to make the gait training and therapy better. And she might need several series of shots for that.
Now we have one more talk before lunch, and it's really exciting. So is everybody okay to go right into it? And the other thing that we have is Cole's electrical stimulation device has been provided to us. So I'm happy to be a subject for a demonstration. So maybe after Chuck's talk, we'll do that. Is that fair? And then we break for lunch. Okay, Chuck, please.